Good afternoon, everyone, and welcome to UCSF Family and Community Medicine Grand Rounds. I'm very excited to welcome our speaker today, Dr. Nancy Burke, who will be talking about a case study in structural racism and urbanism, the neglect of valley fever. This is a topic where I think we're going to find a lot of areas of discussion, and I think it should be a really great, engaging session. Just as a reminder before we get started, today's session is recorded, and if you'd like to rewatch today's session or see any prior grand rounds that you've missed, you can find us. You can find all the sessions actually uploaded on the UCSF Family Community Medicine website for grand rounds. Also, just wanted to thank our tech team today, Benjamin Wallen, Erigo Mitchell, and Roy Johnston for making today's session possible. We are also planning great things ahead as we plan for the Family Medicine Rodnick Colloquium in the spring. And so for folks who are thinking of submitting an abstract, those call for abstracts will be coming out soon, and those are due in January. So give us all something to look forward to joining together for in person in May. For today's session, we are hoping that today's session will be really engaging and interactive. So please use the Q&A box to ask your questions for Nancy. She'll be excited to answer them. And if you have suggestions for either for today's speaker or about future topics that you'd like to hear, please send them to us directly, and we'll be sending out an evaluation link in the chat as well. So for today's session, for folks who just joined, Nancy Burke will be talking about a case study in structural racism and urbanism, the neglect of valley fever. Coccidioidomycosis, colloquially referred to as valley fever by most of us, affects residents in the Southwestern US as well as northern Mexico and areas of South America. About 150,000 people in the United States annually become infected via inhaling spores from this soil-dwelling fungus. And the symptoms of valley fever can be from mild to severe. It can cause chronic lung infection, meningitis, and even death. The Southwestern states in the U.S. are experiencing some of the highest incidence rate of coccidioidomycosis that have ever been recorded. Things like large construction projects and the creation of solar farms and earthquakes have really increased the soil risk of infection for patient populations. And while most of these cases resolve spontaneously, up to about 40% are severe enough to require antifungal treatment, and many spread beyond the lungs. So what's the impact in California? Administrative reviews of statewide hospitalization rates for 11 years from 2000 to 2011 showed 25,000 individuals were admitted in California with valley fever associated issues, and the estimated cost for this is about $2.2 billion. Interestingly, no new treatments for coccidioidomycosis have been approved in the US in nearly 40 years, and the number of investigators studying this disease is very small, and therefore there is little, well, and also there is little pharmaceutical company interest in developing treatments, which is very significant for our patient populations. The fact that the areas most affected in California are also the poorest communities in the state and also home to the state's prisons may have influenced the lack of attention to this disease. So today, Dr. Burke will explore the social, racial, and regional stratifications that inform the neglected status of valley fever. As I mentioned, Dr. Nancy Burke is our speaker today. She's a professor of public health and anthropology, as well as a John D. and Catherine T. MacArthur Foundation Endowed Chair at the University of California, UC Merced. She also holds a joint appointment at UCSF. Dr. Burke serves as the co-director of the UC Cuba Academic Initiative, and her current research projects include focus on aging in Cuba, politics and poverty in relation to valley fever, coccidioidomycosis research, and the roles of community organizations in the COVID response to California's Central Valley and what the implications are for our health moving forward. So with that, I want to welcome Nancy Burke. Thanks for joining us today, Nancy.
Thanks so much, Margot. And thanks for the invitation to speak with you all. I'm really excited to be here. As Margot mentioned, I'm a medical anthropologist, and have been at UC Merced since 2015. Prior to that, I was at UCSF for 13 years, and since I've continued with an affiliation with the Department of Anthropology, History, and Social Medicine. But while at UCSF, I did a lot of research at SFGH and Highland Hospital, and in collaboration with community organizations in the area. So it's really fun to be back in this virtual space with all my UCSF colleagues. But at SFGH, they were most of my work was in Ward 86 in the breast clinic. So it's great to be back today. And I'm going to be sharing some research let's see, how do I get back? Okay, here we go. I'm going to be sharing some research that is part of a larger sort of program of research. So I'm focusing in on valley fever today, but the research that I've been conducting since my move to UC Merced is very much focused on health inequities and exposures in California's Central Valley. And this includes research on pesticide exposure and care seeking for pesticide-related illnesses among Hmong and Punjabi farmers and farm workers, and the challenges of retirement without a safety net for Latino farm workers. I'm also working with families in Fresno and Stockton who have been part of a biomonitoring study for the last 2 years. They've just received results detailing their exposure levels. So they're getting results about their levels of oxidative stress as well as biomarkers of effect. And so my team is working with them to understand how families understand the results that they're getting and how they feel about them and what they might do with them. So all of this work is conducted in collaboration with community organizations, some of whom have their logos on this slide. And many of the staff of these organizations are interested in and have been impacted by valley fever. So it's all kind of connected. And in addition, I think for many of the people who might be here today, most of this work is designed to inform trainings for providers that are serving these populations. So we're doing the inductive work to try to make sure that providers have the information that they need to better serve the people coming into their clinics. So today I'm going to talk through a little bit about why valley fever. I think Margot gave kind of the introduction to that. And then I'll provide a short history of the disease and discuss the conditions of the endemic region here in California, which is the Central Valley. And then I'll describe an ongoing study that I'm conducting in collaboration with colleagues at UCSF Fresno, which focuses on understanding the barriers to effective care for those patients who have the worst form of valley fever, which is coccidioidomycosis. So bear with me as I go through all this. So you may be wondering why valley fever and what is it? Well, as you can see from this slide, there's been a recent increase in or spike in infections. And most recently, as all of this news indicates, following an outdoor music festival in Kern County where 19 people were infected. But this is part of a longer trajectory of increases. The age-adjusted incidence of coccidioidomycosis, which I'll just refer to as Coxie because it's easier, in endemic areas increased from just over 5 cases in 1998 to about 43 per 100,000 people in 2011. And in California alone, incidence has increased more than 213% between 2014 and 2017. And as you can see here, the California Department of Public Health reported 9,000 cases in 2023 and over 5,000 before July 1st of 2024. And there is a concern that cases are underreported because diagnosis is challenging, which I'll talk a little bit about as well. Another reason it's super important to be thinking about valley fever is that in 2022, the World Health Organization recognized fungal diseases as a major threat to public health due to the fact that, and I quote, they're becoming increasingly common and resistant to treatment, with only 4 classes of antifungal medicines currently available and few candidates in the clinical pipeline. So this is sort of neglect of fungal diseases is a real challenge. All right. So what is valley fever? It's, as Margot mentioned, this is a fungal disease that's caused by inhalation of spores in disturbed dust. Coccidioidomycosis is a fungal pathogen that changes its cell shape in response to temperature. So it's a thermal dimorph. So once it's inhaled, the difference in temperature between the external environment and the body triggers a transformation into a large capsule that's filled with spores, or called a spiral. And this is just a slide of one form of Coccidioides immitis. There's another form that's Coccidioidomycosis. But the spores each spiral contains spread throughout the body. And as Margot mentioned, most people living in endemic regions in California, Arizona, New Mexico, Eastern Washington is a new area of concern. Northern Mexico and South and Central America develop immunity because they've been exposed at some point in their lives. And some of them just experience like pneumonia-like symptoms, and some, for reasons scientists don't yet understand, develop disseminated disease, which is the worst form. And diagnosis, as I mentioned, is really difficult, and that's why we're not sure if the numbers that we see are actually correct. It's often mistaken for pneumonia, and for some people, this means that the disease progresses to its most severe stage before appropriate treatment can start. So patients are often initially treated with antibiotics, which research conducted by some of my colleagues at UC Merced, in Katrina Hoyer and her colleagues in their lab, has shown that this treatment with antibiotics can actually clear out the lung microbiome and enhance the growth and spread of spirals within the body. So appropriate diagnosis is incredibly important. So as Margot mentioned, no new treatments have been developed in over 40 years. And much of what is in use has been derived from historic precedents and observational studies. There's a lot of concern about the side effects of the treatments that are available, and patients argue that the treatments are often worse than the disease itself. There's a lot of testimonies about this. And this is because fungal cells, unlike bacteria, resemble human cells, and so the treatments are toxic to both the fungus and the host. And the side effects of antifungal treatment include dry skin, nausea, abdominal pain, and photosensitivity. And in a region like the Arizona and this California Central Valley, where there's a lot of sunshine, this photosensitivity can be super problematic, and a number of patients end up getting melanoma related to as a consequence of their treatment. Some patients with severe cocci are treated with infusions of an antifungal medication that is called amphotericin B, which is nicknamed amphoterrible, as the slide shows, because the side effects are reported to be similar to those experienced when receiving chemotherapy. And the most common form of treatment are antifungal azoles like fluconazole, which have to be taken for life for those who have advanced disease. And they're not curative. And their failure is well reported as well. So those who do have the most advanced form of the disease, coccidioidomycosis meningitis, they also often have to have surgical ventriculoperitoneal shunts placed to relieve elevated intracranial pressure as a result of inflammation. And these shunts are also known to fail and require surgical revision. So the treatment is just very, very challenging and not easy. So there is no vaccine to prevent valley fever infection in humans. A vaccine was introduced in the 1980s, but it wasn't shown to be efficacious in clinical trials. So there is a canine vaccine that is in development and just about to come to market. And that has been funded largely by a collectivity of dog owners in Arizona. And much of this research is coming out of the University of Arizona. So it's kind of interesting that we have the canine vaccine, but the research on a human vaccine is pretty slow. And there's a lot of reasons for that, which I'm happy to talk about if anybody has any questions. So I'm going to shift now to just kind of a short history of the disease to give you a sense of what is known and what's commonly reported. So the first case of valley fever was diagnosed in 1892 in Argentina. And a year later, a Central Valley, California farm worker from the Azores entered a San Francisco hospital with similar skin lesions. And descriptions of this patient's disease progression and slow demise, which was largely due to the treatments that he was subjected to, is reproduced over and over in pretty much every history of the disease. And outbreaks have been chronicled at various points since this time. And I'm just going to highlight a few that kind of give us an illustration of the impact on the landscape in California. So in World War II, the US Army sent recruits to build airstrips near Bakersfield, California, which is in the southern part of the Central Valley. And hundreds of the airmen that were sent to build these airstrips fell ill. There was a bit of research that was conducted on this outbreak by the Department of Defense, and that research the findings from that research have had a long-term effect on the understanding of the disease, and particularly in an understanding or thinking through who gets the worst cases of coccidioides. At the time, the worst cases in this group were African American and Filipino airmen. So German prisoners of war and Japanese Americans who had been taken from their homes and held in internment camps in Arizona and Central California were also infected at high rates at the same time. And the POWs were relocated from these camps, but the Japanese citizens were not. In 1982, there was an article in People magazine that was reporting on the potential vaccine that never came to be. And in this article, valley fever was described as, quote, so bizarre that some have termed it a cult. And this article recounts a 1968 outbreak when students from UC Davis excavated a Native American burial site near their campus. And at this time, 11 of the 23 students who were involved fell ill. And there was another excavation near Chico in which 61 of 103 students who had traveled from New York to participate in the excavation were infected. And the article suggests that, quote, to some lurid imaginations, it's a curse that strikes those who tamper with ancient and sacred burial sites, end quote. The disturbance of the soil that does occur with construction, excavation, and dust storms is linked to infections. So these kinds of spikes in infections have been linked, have occurred as a result of the development of solar farms and the construction of solar farms in Southern California, with Caltrans construction projects, and with major dust storms like the one that's depicted here. One somewhat famous example is known as the Tempest from Tehachapi. And this was a dust storm that followed a long drought in 1977. and in which the dust was stirred up by winds that blew over the Tehachapi Mountains into Bakersfield. And this spread dirt over the entire valley, which was over 400 miles all the way north to Sacramento. And the drought was ended with a heavy rain, but before the rain, there was like this haze that was hanging over the valley. And the rain turned the dust to mud and ended the drought. And in the following week, Sacramento County recorded over 100 cases of cocci. So significant outbreaks have also occurred in the region's prisons. In 2005, there were 166 prisoners in Pleasant Valley State Prison came down with cocci, and 4 died, and over 30 were sent into the hospital. The Pleasant Valley Prison and the Avenal State Prison were actually built on the site of the World War II prison camps that I mentioned previously, where the POWs had been infected. And this is an area that public health epidemiologists have termed as hyper-endemic. And subsequently, people have asked, why did we build prisons there when we knew that this is a very high-risk area for cocci infection? And the prisons that we have in California, and there's 22 in the Central Valley, house a population of 97,000 adults, 96% of whom are men. And the majority are not from the Central Valley, so they have not been exposed previously, likely to valley fever or cocci. And the largest percentage of prisoners in the system come from Los Angeles County. So in addition, following the 3 strikes legislation in the US, there was a large influx of Black and brown inmates in California prisons, as you all know. For example, African Americans make up just 6.6% of California's population, and yet they make up almost 30% of the prison population. And I mentioned that Department of Defense research from the 1950s that suggested that African Americans may experience more, and Filipinos may experience more severe disease when infected. This research has actually current explorations of this potential association have influenced prison policy so that if you are subjected to jail you are not able to, if you are African American or Filipino, you cannot go to Avenal or Pleasant Valley State Prison. Now I'm going to shift a little bit to the Central Valley and give you a sense of the region in which all of this is occurring, a little bit more of a sense than I already have. So the Central Valley is described as among the most engineered landscapes in the country. It's the country's breadbasket. It's intensely agricultural, highly industrialized, and produces most of the country's vegetables, nuts, and fruit. And it also has the highest rates of food insecurity in the state. And this production happens despite periods of long drought and episodic flooding. These long periods of drought and lack of rain also contribute to increases in forest fires in the region. So for example, in 2020, I'm sure you all remember, the Creek Fire ravaged the Sierra Mountains from September through December, and it destroyed over 850 structures and burned over 379,000 acres. So that's just to give you a sense. So we've got this heavily industrialized landscape. We've got a daily pesticide exposure or daily pesticide application to support agriculture. We've got wildfires. And then we have a largely immigrant workforce that is working this land and that is experiencing exposures to these pesticides, to the potential, the dust that is released with agriculture, and they're largely working below the poverty line. The majority of farm workers in California earn $18,000 a year. And many also lack a legal residency, which means they have limited access to social services, including unemployment and healthcare, despite paying taxes. As I mentioned at the beginning, I have research studies that are engaging with Hmong small-scale farmers, as well as Punjabi farmers and Latinx farmers. So it's a diverse population, but there is a large farm worker population in the region. In addition, with all of this agriculture, we have a need for water, right? And so the ground literally under our feet in the Central Valley has been sinking since 1925. And as you can see here, just between 1988 and 2016, the land decreased by 6.2 feet. This is because large corporations, agricultural corporations, are extracting water from the ground at much higher rates than we can replace with rain and snowmelt. So the kind of dance that the region plays between heavy rains, flooding, and severe drought also influences cocci spread, which is a reason why the Central Valley alongside Arizona is considered a hotspot for the fungus. As I've mentioned previously, the fungus proliferates during rainy seasons, and then the spores dry out in long dry periods. And when this happens, the walls of the spores break and they're carried in the air in disturbed dust. And if there's a windstorm, an earthquake, or major construction project, that's when the risk goes up. Despite this, it's kind of interesting that there's no consistent communication strategy in place to warn Valley residents of increases in cocci risk, which is clearly a public health issue that needs to be addressed. So I mentioned that we have all of these exposures in the air, from pesticide to wildfire smoke to dust, which means that we have high rates of PM 2.5. And this has resulted in chronic asthma becoming a normal part of childhood for the majority of the 4 million people that live in the region. And we have the San Joaquin Valley, which is a subset of the Central Valley. It's 8 of the 11 counties, has the unique honor of being featured on the EPA's website, where it's described as home to some of the nation's worst air quality, high rates of childhood asthma, and contaminated drinking water. So just to wrap this up, in addition, a significant proportion of the population, 41%, is covered by Medi-Cal, which means that they are under the income level that's necessary to receive public insurance. 4 of the region's major counties are ranked 52nd, 53rd, 49th, and 50th for health outcomes out of California's 58 counties. And despite this poor health status, there are substantially fewer medical providers in the region than in coastal areas of the state. So for every 100,000 residents, the Valley has 39 primary care physicians, 22% less than the state average of 64, and an even lower share of specialists. And this is one of the issues that Margot is working on in collaboration with a team of folks at UC Merced and UCSF to develop and really create a sustainable medical education program. So that was just to set the stage of why this is important and how neglected the region is. We're dealing with intergenerational poverty, environmental exposures, and a lack of healthcare infrastructure. So in this context, layering on this pretty severe chronic exposure to a potentially severe chronic disease that requires lifetime management is a real challenge. So a physician at UCSF Fresno, Geethas Sivas, reached out to me because she's an infectious disease doctor, and she had started looking at her patient population and realized there were some real problems with supporting the patients that were coming in with severe forms of coccidioidomycosis or valley fever. So she conducted a retrospective analysis of patients who were seen in her clinic between 2010 and 2020. And the findings were really disconcerting. So I've mentioned the social and economic context of the Central Valley, and what her work really showed was the challenge of mapping the need for long-term care and lifelong medical management on already really complicated and complex lives. So as you can see in this abstract from the paper, she found that 43% of the 133 patients that were seen in the clinic for advanced disease of coccidioidal meningitis experienced challenges adhering to treatment, and almost 53% required revision surgery due to shunt failure. So I mentioned that there's the need to place a shunt because of the intracranial pressure that causes these really horrible headaches for people. And these fail. And so people often had to have these replaced more than once. And rehospitalization rates were high due to complications with the disease. So clearly, this shows that we need to do something about care, knowing that these patients are suffering from a neglected disease for which there hasn't been any treatment innovation in over 40 years. So we decided to talk to the patients and try to figure out what's going on with them, what their experience is like, and what we might be able to learn from them about how to improve the care that they're receiving, recognizing that there are a lot of limitations that we're working within in terms of the structures of their lives and the limitations of the healthcare system. So we are conducting inductive conversational interviews with 25 patients who've received a diagnosis of coccidioidomycosis meningitis within the last 10 years. And we're talking with them about their experience of diagnosis, their understanding of their disease, what kind of treatment they've experienced and what kind of follow-up care they've had, what challenges they may have experienced taking their medications, what kinds of side effects they've had, and any gaps in care that they've experienced. And once we complete these interviews, we're going to be using some of our findings to develop an online survey of hospital staff and providers to get a sense of practice and organizational level factors that might impact care as well. And we're going to be asking in the survey about their patient population, the management processes, and the resources that they have, in addition to any other issues that come up in our that we learn from our inductive work that we want to ask in these interviews. So this is ongoing research, and we just have, we've just really begun, but we have some initial findings that I thought I would share with you to give you a sense of some of the challenges that are coming up. So across the interviews that we have conducted, we found that there are really low levels of awareness of valley fever prior to diagnosis. And this is even among people who've grown up in the Central Valley. They had, very, very little understanding of the illness and definitely did not think it was as serious as their experience of the illness has become. We also found that people had a very circuitous route to diagnosis that allowed for disease progression prior to treatment commencing. And so I'll just give an example of one patient that we interviewed who initially went to urgent care with severe headaches and a cough. And from that first urgent care visit to the ER visit where he was finally diagnosed, 3 or 4 months passed. And this patient was really confused by the initial diagnosis and didn't understand the gravity of it. He talked about having to look up the terms that were used on his phone. The doctors just kind of kept telling him it just takes a little while to get better. And he said, sometimes I feel like I wasn't heard because I feel like I could have gotten this all solved much sooner, but it just took them a while. So he just described this kind of going to urgent care, going to the ER, going back to urgent care, being given an inhaler, being given something for his headache, being told that it was a tension headache and he needed to reduce his stress, and then finally making it to the ER where he was diagnosed. Everyone we've interviewed talked about getting swabbed for COVID, but not getting tested for valley fever. And kind of the frustration about how long it took to get to the point of getting tested for valley fever. We also found that from the interviews that we've conducted that there's an uneven understanding of the need to consistently adhere to taking their medication. People not really understanding that if you stop, then there are repercussions that your disease can actually get worse. But it's because the side effects are challenging for these men, and it's all men that we've interviewed so far. And there's also concern about long-term management and what the future holds. These are young men who have worked worked outside, volunteered for CAL FIRE, work in agriculture, work in warehouses, physical jobs, and they're finding themselves now really frail and cognitively challenged because of the medication. And so there's a lot of concern about what the future holds for them and their families. So I'm just going to wrap up. I think what I have tried to illustrate here through these different pieces of the history of the disease and its sort of slow coming to attention and the social and political and economic context of the Central Valley is that the piling on of environmental exposure, intergenerational poverty, inadequate healthcare, and literally the ground sinking, it just seems very symbolic, illustrate the many ways that the region has been shaped by structural racism and urbanism. I mean, this stuff doesn't happen by mistake, right? There's a reason why people are neglected. And the slow recognition and investment in furthering the science of coccidioidomycosis, developing curative treatments, developing adequate preventions, can be considered a case of structured neglect. I think I've also tried to show that coccidioidal meningitis is really difficult to manage. And our initial thoughts are that the care may benefit from a complex care management or navigator care delivery model, kind of a wraparound care for these patients who are dealing with a lot of complexity in their lives, especially because, as people who have been working in these physically taxing jobs and no longer able to do that, there's potential housing insecurity as well as employment insecurity. And I believe addressing health disparities in this region really should be a priority. And I think that that's pretty clear. And that there's a need for effective outreach campaigns to raise awareness about valley fever. I mean, it's just been really surprising that people who've grown up in the valley have very little awareness of it. And also the need for provider education, with particular attention to urgent care centers. I mean, it's striking to me that all of the patients that we've interviewed so far started their treatment or diagnostic trajectory in urgent care. And there is very little awareness among the providers there about valley fever. So with that, I will wrap it up and say thank you, and I'm happy to take any questions.
Thank you, Nancy. I really want to thank you for an incredibly thoughtful, provocative, and honestly, somewhat disturbing talk about what's been going on in the Valley and the factors behind it. Um, I think, well, first of all, please, if folks have comments or thoughts for Nancy, please feel free to use the Q&A to share your thoughts or questions. But I have a question of my own first. I mean, your whole talk was very compelling, and I have to say, you really got me with the dog slide. Can you talk a little bit more? I mean, uh, can you talk a little bit more about the factors behind that? I mean, here we have, there's a vaccine in development for dogs, and there isn't a vaccine for people for valley fever. Can you just tell us a little bit more about that? Thanks.
Sure. So So one of the things I've been doing in addition to this work in Fresno is interviewing scientists who are involved in studying valley fever, because I was trying to understand why things have moved so slowly. And part of it is that it's a very small community of scientists, and their ability to get funding for their research has been challenging over time. And so in 2019, the NIH did develop these centers for excellence in valley fever research, and they're interdisciplinary centers, and they do include some attention to vaccine development. So there is some work going on. For example, there's a team in Washington that's using a non-human primate model, building on research that some of them had conducted uh, related to COVID vaccine development, trying to apply that same model of vaccine development to coccidioidomycosis. And so there is some work, but it's very far down the line. And there's a lot of concern about bringing it to market, because there's scientists talk about the fact that, if we look at how the COVID-19 vaccine was received in the context of a worldwide pandemic, how likely are people going to be interested in a vaccine for valley fever that only affects a certain portion of the population in certain regions of the world? So it's complicated, but I do think that it is shocking that there's been much more advancement in the vaccine for dogs than there has been for people.
Yeah, I completely agree with you. I mean, it does make me think a lot about the structural features that are behind a lot of what we're seeing in terms of no vaccine. And you also sort of touched on delay in diagnosis for patients. And I was wondering if you could talk a little bit more about sort of the structural factors that go into that, because you mentioned that, of course, most of that comes in an urgent care setting. And I think many of the attendees here, I'm a primary care doctor. I'm just curious about what are some of the structural pieces that you think could help us do a better job in making that diagnosis. Like you mentioned, everybody who came in said they got swabbed for COVID like immediately. So could you say a little more? Thanks.
Yeah, sure. So I think I mean, I think it's a real challenge, because it's not what providers are first going to. And patients are presenting with a cough, with a severe headache, with joint pain, and so they're getting an inhaler for their cough. They're getting Excedrin for their headache. And I think it's really just, I mean, in terms of structure, I think first of all, it's, our short time that we have with patients, right? It's like really taking the time to think about, okay, if this is somebody who works outside and who's coming in with these symptoms, maybe valley fever is something I should be thinking about. But because of the short amount of time that people have, that providers often have, they're addressing the piece, the headache or the cough, but not necessarily able to put them all together with the story of this person's employment and exposures. Um, but I do think that hopefully with possibly a positive outcome of this spike is that it is going to raise awareness and will cause people to think, oh, wait, maybe I should test for valley fever as well.
Thank you. Thanks for that answer. And then on a very related note, Marlena asked a great question, which is, has there been any research regarding the use of spherosol skin testing as a screening tool in occupational health to raise awareness of non-immunity for our patients?
Yeah, so I'm not sure about that. I know that it's been used a lot. So there is one processing center in the Central Valley for the prison system, and they are using this test well, prisoners who are brought to the processing center can choose to take the skin test to see if they've been exposed or not. If they have been exposed, they can go to one of those prisons like Pleasant Valley or Avenal. If they haven't been exposed and they're African American or Filipino, they can't go to those prisons. And that's it's an interesting process because the prisoners can choose whether they want to get tested or not. And some will choose not to get tested because they want to go to one of those prisons because it's closer to their family. So that's the context in which I'm really aware of these skin tests being utilized in an active manner. The diagnostics that the patients that we have been interviewing have described include getting an MRI, getting a lumbar puncture, so a little bit more extensive diagnostics.
That's really interesting. Um, Appreciate that answer. And then Megan, I wanted to give you a chance to ask a question if you had a question, but if not, I have another question to ask too. So we're all lining up.
No, thank you. Thank you, Dr. Burke, for this really illuminating presentation. And this is an excellent conversation. It's just reminding me of a time when our department had a very strong partnership with the California Department of Corrections right around the time of 2005. And I just had noticed that Shira Shavid was one of the leaders, and she's on the call today and leading an effort to address some of the deficiencies in the care that was being provided in the state prison system. And I was also involved in that too, providing, HIV care. So we did hear about this event of building and this hyper endemic area that you described, in Pleasanton and also in Avenal, and how that was just a real incredible missed opportunity and representation of the structural racism that you are in the social and environmental drivers of health that impact this population. A couple of questions related to that you've already addressed with the skin test, but I just am curious about what are some of the things that we can think about and as far as interventions at the prison care level because of this population and being high risk. And then the second question I had was around what I'm gathering is even an algorithm that is dependent on not only the skin test, but also on race and how that's as you know is becoming increasingly under scrutiny because of the implication that race is a biological concept as opposed to a social construct, and so just some thoughts there as well. And then I just in general, this lack of awareness in the region. We have our FQHCs that are there. Of course, there's chronic shortages in workforce and primary care workforce in that region. But just some thoughts in general around how to intervene, given what you presented.
Yeah, thank you. Yeah, I mean, it's really interesting thinking about I know that there was some, the prison system, health system responded to those outbreaks with some environmental changes, planting shrubs around the prisons to kind of tamp down dust, also watering the outer areas to try to keep dust down, things like that. I think so. But I think one of the challenges there, at least from the presentations I've seen at the Cocci study meetings from the scientists who've worked on that, is that so many things happen that it was unclear it was difficult to tease out what was effective and what wasn't in terms of reducing spread. This question about this association of race and more severe infection or getting the worst case of coccidioidomycosis or coccidioidal meningitis. I think it's a question that a lot of researchers right now are trying to figure out, because like I said, there's this legacy of this work from the 1950s from the Department of Defense. But I was at a Cocci meeting where an epidemiologist said, that research was conducted on the airmen at these in Bakersfield. And it showed that African Americans, Filipinos had the worst rates, but they were also the ones digging the ditches. So they were the ones that got the highest rates of exposure, right? They're in the dust. So, there's just so many questions about how this was produced and why it has such a strong legacy. So there are immunologists and other sort of bench scientists that are trying to look at ancestry, because there's also cocci in northern Brazil that people are getting, but they're not getting it. These are Afro-Brazilians, but they're not getting the worst strain that we're seeing sometimes here in the US. So there's just a lot of questions about genetic ancestry versus social construction of race and the ways and what questions we ask in research and why. So I think it's a really important area, and there's a lot that still needs to be done there. In terms of this question about awareness in the region and thinking about FQHCs and provider awareness, I was just talking with a colleague at UC Merced about this. We're in the middle of this endemic region, right? And we have all the schools in Merced have these flags that they put up for air quality, right? So that you can know whether your child should play outside on that day, or whether it's dangerous for them to be outside if if they're sensitive. I mean, it seems that we should be doing something similar to that when there are high risk events. But we're also a region where, we're seeing construction up and down the valley for the logistics industry, right? I mean, for Amazon, for Walmart, these large warehouses. So all of that is creating the potential exposure as well. Yeah.
Thank you, Nancy, for a really, really thoughtful response. And I think we only have time for one more question, which is from Matthew, who put in the Q&A. Growing up in the Central Valley, I knew about valley fever, but the information I knew was incorrect about what valley fever really is. How would we demystify what valley fever really is, especially when there's a lot of other concerns in the Central Valley, such as obesity, poverty, many of the things that you mentioned?
Oh, that's a really great question. I mean, I think this is where, um, thinking about different communication schemes can be really useful. I mean, just think about animations, like memes. We could just clearly explain using social media, using, just creative little cartoons, how valley fever works, like how it moves through the air, how it moves through the body, how it changes. All of that. I think there's so many opportunities with creative media to get this information out there. Um, I'm curious about what was the information that you had learned. I mean, I think what we're hearing from the people that we're interviewing is even when they had family members who had been exposed to valley fever, they thought it wasn't that big of a deal because so many people do get it as, as like flu-like symptoms or pneumonia. And then here these young men are coming in and they're, debilitated, and they have the worst form. So I think that piece is the piece that people need to learn about, because I think the common understanding is it's just not that big of a deal. It's just something that you get exposed to, um, but not that you could end up, on medication for your life, entire life.
Thank you, Nancy. Thanks for that answer. And those of us who are working on medical education at UC Merced have some opportunities for intervention here. I said that Matthew's question was going to be our last one, but there's a really good comment in the chat from Shira that I want to read before we conclude, which is Shira wrote, "Great presentation, really important topic, and shows systemic racism impacts health. Glad to hear that CDCR is addressing this issue to prevent coccidioidomycosis, but I see patients here in San Francisco post-release from prison and still see many Black and Brown patients with coccidioidomycosis after their release. There's data that shows that cancer is diagnosed at higher rates after release than during incarceration. This raises the question for me about frequency, rates of diagnosis of cocci before versus after release. Do you know any data related to that?" And I'm actually, because we're going to run out of time, I'm actually going to leave that as a thought bubble question to encourage actually all of us to reach out to Nancy about, because I'd like to know the answer too. And then Marcos also just read another comment in the chat that I want to make sure that we get to too, because I think we're showing ourselves that we've got room for discussion, which is, has the virulence of the fungus changed over time so that the new cases are more severe compared to the ones described during the war, which is an actually also fantastic question. The fact that we are running out of time for questions makes me feel certain that there's a lot more work to do in this area, and then we've got a really talented team that hopefully can engage with the community and further this work. I want to thank you, Nancy, for an amazing presentation, but also give you a chance in the last minute to just either respond to those questions or just send us off with some of your thoughts to wrap us up. Thanks.
Thank you so much. Those are really great questions. And I have not seen any analysis suggesting that there is a change in the virulence, but that's a really, really interesting question that I'm going to go back to the scientists I've been interviewing with. Yeah, I really appreciate the connections with and the thought shared about this as a post-diagnosis, or whether people are getting diagnosed in prison or if it's something that they're finding out after. I think that's a really important question as well. And I think anyone who's interested in this topic, we've got a great group of people at UC Merced who are looking at it from from immunology to the social and political aspects, and they're always looking for partners and interested conversations. So we look forward to hearing from you.
Thank you so much, Nancy. Thanks for a fantastic presentation today. Thank you to everyone for joining us. And this is really the beginning of this discussion, of this conversation, certainly not the end. And I look forward to hearing more work as we move forward together. Thanks to everybody. Bye-bye.
Bye.
Have a good day.